Hello, my name is Pamela Avascal and I am presenting the second HMP webcam. And I'm following the trauma group at Del Sol Medical Center, and we encountered this patient in the ER. He is a 26-year-old Hispanic male that came in with a chief complaint of abdominal pain. He stated the pain began sudden and severe, sharp, concentrated to the epigastric area at 8 a.m. on presentation day. He states the pain stayed in the epigastric area, then diminished, and returned subsequently with about 30 minutes to an hour between pain episodes, of relief between pain episodes. He stated his pain became worse as the day progressed and was at its worst at about 12 p.m., which led him to have his mother bring him into the ER. He did not take any pain medication and has not had anything to eat since breakfast due to the severity of his pain. The pain radiated to all of the abdomen and no longer was concentrated just to the epigastrium on presentation and during assessment. He stated nothing made the pain better, and he had just been laying in bed prior to coming in, and it had made it difficult for him to walk and also had caused some shortness of breath. He denies medical history and no surgeries in the past, denies allergies to any medication, and also denies using any medications on a daily basis. But in speaking to his family later, they did reveal that he does use NSAIDs on a daily basis for back pain that he suffers and relates to his job. He has not sought professional medical attention for it. He does state that he uses cocaine occasionally, but has not used in the past several months. He works as a construction worker, lives in a home with his mother and his sister. He states he occasionally drinks on the weekends about a 6-pack of beer. He denies smoking tobacco, and he no other and denies any suicidal thoughts or actions. On review of systems, patient denies fever, chills, or night sweats. Respiratory dyspnea due to pain in abdomen. Cardiovascular, no chest pain or palpitations, no peripheral edema. GI, severe pain to wall of abdomen, had a bowel movement the day prior to arrival and was tolerating diet well, and was not having any nausea or vomiting, no bloody stools, diarrhea or constipation. Skin, no rash, bruising, or lacerations. On assessment, patient is in bed, awake and alert, in obvious distress. He has difficulty breathing and answering questions due to severity of pain. He appears well nourished and overall good with good hygiene, able to speak fluidly and responds adequately to questions asked. Peripheral IV to right AC, infusing normal saline at 125 mL per hour with no signs and symptoms of infiltration, and mother is in at bedside. Vital signs, blood pressure 145/68, heart rate 95, sinus rhythm, respiratory rate 20, pulse oximetry 98% on room air. He has a temp of 98.9. He weighs 75 kilos and is 66 inches tall. On assessment, neurologically awake, alert, and oriented ×3. Cardiovascular S1 and S2 audible. No murmurs or gallops present. Respiratory, noted shallow and uncomfortable respiratory effort due to pain. Lung sounds clear to all lobes, no adventitious sounds. GI, abdomen is rigid, tender, and painful to light palpation. Bowel sounds are present. Skin is warm, dry, and intact. On diagnostic lab work, pertinence for him, his CBC, white blood cell count was 9.9, hemoglobin 10, hemotic rate 33, AST 30, ALT 45, amylase 56, and lipase was 93. H. pylori was negative. He did have a CT scan of the abdomen, and it showed ulcers and a perforation. Diagnosis for this gentleman was acute abdomen due to perforated duodenal ulcer. And the plan for him, he did go to surgery with for an exploratory laparotomy, which showed the perforation and was repaired at the time. He will be admitted after recovery to the medical surgical floor and Lab work for the morning, CBC, CMP, and monitor electrolytes for any need for replacement. We'll have IV fluids until he is able to take in PO. He will have IV morphine for pain until he is able to take PO, which will be changed over to Tylenol number 3 for pain. Also for this gentleman, teaching requiring discontinuation of NSAIDs used to avoid future problems, and monitor her surgical wound and drain that was placed during surgery. Differentials for this individual: acute gastritis, pertinent positive for this diagnosis. Most common presentation of acute gastritis is epigastric discomfort or acute abdominal pain, which he presented with, and occasional patients present with nausea or vomiting, which he did not have. Another differential, acute cholecystitis, and a pertinent positive for this upper abdominal pain, which begins in the epigastric area. But a pertinent negative is that his pain did not radiate to the right upper quadrant, which is a finding in acute cholecystitis. Also, a patient did not have nausea or vomiting or fever, which is commonly present in patients presenting with acute cholecystitis. That was my H&P, and thank you so much.